think you have an incredible team and unique set of services. So I'd love to share some of my insights and experience in the area of cancer-related cognitive challenges. And the overarching objectives for this morning for me would be to talk a little bit about the various etiologies that are implicated in cancer-related cognitive impairment, and really to spend the bulk of the time thinking through some of the lifestyle strategies that seem to be promising for mitigating some of the symptoms among our cancer survivors, and to kind of parallel that theme to recognize opportunities for research of lifestyle strategies. And I'm really hoping and looking forward to saving some time at the end for any questions and discussions. So I realize we probably have a mixed audience, and for some of you this is far too fundamental, but to get us all on the same page and platform, these are the typical things that I see, and I imagine most of us who help with the care of our cancer survivors often hear, where we have a patient during or after treatment who may be complaining of memory lapses. They'll say they have a hard time focusing or concentrating or attending to items. They have a harder time with short-term memory, multitasking, whereas people say they used to juggle 2 or 3 things at once. That may be more difficult. It just may take more effort or a little bit more time to process information. Or, of course, one of the ones I hear most often perhaps is there's a word on the tip of my tongue and I just cannot seem to pull that word out. So word retrieval can be a challenge for some. Of course, the challenge is there's nothing pathognomonic about any of these symptoms in CRCI. So some people can have just 1 or 2 of these challenges, and some may struggle with a whole variety of them. How common is this? And of course, this varies based on which study you look at, which population you may be analyzing, how you're analyzing the information, with what kind of assessment. But my general sense is that about 1/3 or so, actually, which really challenges the etiology of CRI, may have some cognitive issues before they had any surgery, chemo, moment, because it really was, this was really one of the insights that led to changing the name of CRCI, which often in the lay world is called chemo brain, which implies that chemotherapy is the sole etiology to cancer-related cognitive impairment. Many people may have challenges during the thick of, surgery, chemo, radiation, but it really comes, in my opinion, to the forefront when our patients are done with surgery, chemo, radiation. They're trying to integrate back into their lives, into their roles and jobs and whatnot, and then they're struggling. And again, this may vary from 30, 40, 50%, depending on which study we look at. I do want to highlight the bottom that, and again, this varies depending on which study, but in this one survey, 75% of people wish they had been receiving support for cognitive training of some kind. So it is a challenge that our patients hope and wish to have treated or mitigated in some way. And I just want to emphasize that one point before we start. Now, there are many challenges with the medical literature in this space, and it's getting much better over the last 5 years. But at its inception, a lot of the studies did not have an assessment of someone's cognitive function before they had chemotherapy, which is a challenge, again, because there may have been some cognitive issues before. There are different populations, different neuropsych batteries. People have different stages of disease treated with different types of chemo or immunotherapy or radiation therapy or degree of time in anesthesia and other surgical factors. And I think one of the greatest challenges for those that were looking for something cut and dry is that, and it varies again based on study, but oftentimes what our patients describe in terms of the cognitive distress that they're experiencing may not necessarily match up with objective neuropsychology testing. And there's a number of reasons that have been given that we can talk about it should time allow. But from my perspective, again, if we're thinking about this pragmatically, right, at the end of the day, as clinicians, we're here to manage what our patients are telling us. And at least from a perception of perceived cognitive dysfunction, you can see that here's just one survey, there are many others, that a vast majority. So obviously, if you look at the first column, yes, our brain tumor patients, because anatomically they have a different process that is underlying their cognitive issues. But if you look at, again, our breast cancer survivors, lymphoma, colorectal cancer, etc., there's anywhere from a third to 50% are subjectively reporting cognitive symptoms. In this one survey, depression and having received chemotherapy seem to strongly correlate, but there's other factors as we'll talk about. So this is really, when we talk about the pathophysiology or the etiology, this is really where we spend a lot of our time in our cognitive rehab program that I'll introduce later this morning, with the idea that if our patients have some insight into the factors that may be playing a role in their well-being, that insight can catalyze change and allow for action to help improve our overall quality of life. So I'd like to, again, review some of the things that I see implicated and again, opportunities for lifestyle interventions in this space. So the different factors, obviously, again, in the lay world, this was dubbed so-called chemo brain or chemo fog or something along those lines. And so obviously, the chemo, right? I mean, we think might be implicated. The chemotherapy, the surgery, the anesthesia, the radiation therapy, all of these obviously may be implicated in the symptomatology. It turns out there are some that have hypothesized and written about the idea that there may be a genetic predisposition to some of the cognitive changes. And I think this is also important to think about from another perspective, in that, again, as I alluded, about a third, and again, this varies based on studies of breast cancer patients, actually have cognitive issues before having any chemotherapy. And there may be a number of reasons for this. One of the basic ideas is that the DNA changes that may have led to the breast cancer, for example, they may have shared factors that may also have led to, for example, cognitive decline. And again, these changes may become more magnified with surgery, chemo, and radiation. So I think we have to be careful in blaming all of the cognitive issues just on the cancer experience, at least for a subset of our patients. Hormonal changes, right? So women who are put on tamoxifen or Arimidex, or men that may be put on testosterone blocking drugs for prostate cancer, for example, this may play a role. This is a study from Patty Gans's group at UCLA, where they were, again, looking at subjective cognitive symptoms over time, and the higher on the y-axis, the more cognitive symptoms. And you can see, compared to having no endocrine therapy in the blue, both the tamoxifen group and the aromatase inhibitor group had a higher incidence of cognitive symptoms compared to having, again, no endocrine therapy. And this is a more recent analysis from Lynn Wagner's group. And this was interesting because she was able to, in this randomized clinical trial, look at women who were kind of in the intermediate stage, and they could be randomized to getting chemotherapy or not. And so if they had, just looking at all the numbers together, if they had chemotherapy and endocrine therapy, you could see there were, there was an increase in cognitive symptoms compared to the group that had endocrine therapy. But it's important to highlight that both groups had perceived cognitive impairment compared to their baselines. And as kind of makes intuitive sense, the women who were premenopausal and had endocrine therapy, because they're just put into sudden menopause with these cocktail of drugs, seem to have as many cognitive symptoms as the women who had chemo and endocrine together. So this is another insight that these hormonal drugs might be playing a role in the cognitive symptoms for some of our patients. And again, we know that people have other medical issues, right? We may have thyroid issues or anemia or cardiac and lung disease and other comorbidities. We may be in pain, which make it hard to think straight. We may be on things like gabapentin and pregabalin and opioids to manage pain, which can make cognitive issues more problematic. Some of the nausea drugs, possibly, compazine or Zyprexa or others that may be used, may be contributing. So there's all these other medical factors and comorbidities that I can't emphasize enough may be playing a role, and that's why I think it's really important to have a holistic view on these symptoms. And sleep, we were talking about this quite a bit yesterday with your team, with Dr. Schatz and others, that poor sleep may be a major driver in some of these cognitive symptoms in the cancer setting. And we know there are all kinds of reasons why individuals who may be going through treatment can have difficulty sleeping, whether it's hot flashes or anxiety or sleep apnea or other factors. And even though they're not the same, even though we know cancer-related cognitive impairment is not equivalent to depression or anxiety, certainly there seems to be a significant amount of overlap. And so managing the symptoms of depression and anxiety becomes important. Feelings of chronic stress or perceptions of chronic loneliness may play a role in the symptoms of cognitive impairment. This is probably less hashed out, but we imagine that having really poor nutrition may contribute to how our cognitive processes are working. I'm obviously biased as a rehab person, but deconditioning, lack of exercise can contribute to cognitive symptoms. And again, many in this space are arguing that chronic inflammatory cytokines, along with mitochondrial dysfunction, as a result of this whole process and all these factors, perhaps may be one of the primary drivers of cancer-related cognitive issues, which is why I have this topic highlighted in yellow and bolded. So that's where I want to spend a little bit of time, because this has got a fair amount of attention in the literature, where there's this idea that our bodies are producing these inflammatory cytokines either in response to the cancer or the chemo radiation surgery, or maybe even the psychological distress. All of these factors may contribute to the production of these inflammatory cytokines that then may be one of the primary drivers, at least in part, of cognitive issues, cancer-related fatigue, and maybe even some of the symptoms of depression. And so out of this idea emerged this hypothesis that somehow the survivors that are experiencing more of these cognitive symptoms somehow seem to be aging faster, or their brains maybe seem to be aging faster compared to, let's say, an individual that didn't have cancer, or maybe had cancer, but their cognitive symptoms have kind of bounced back to normal. And so if we believe this idea that accelerated aging may be contributing to our cognitive symptoms, in my mind, that really opens the door in thinking about, again, how we live our lives and our lifestyles, how that may help, again, either mitigate or possibly even reverse some of the cognitive dysfunction that our patients experience. And before we talk about the lifestyle measures, I just need to point out very briefly that, at least in my perception, and we could talk about this, and again, most specialists in this area would argue that there is no clear evidence for the value of any drug in managing cancer-related cognitive impairment. There have been studies on like Ritalin, methylphenidate, or modafinil, or memantidine. And I can tell you personally, and again, being a bit simplistic about this, I may use some of these drugs for our brain tumor patients, or for our patients with stage 4 cancer, or people who are going to be in treatment indefinitely, and there may be a role. But for our patients who are, in remission, cured, survivors in that sense. The studies are mixed at best. And so we can't, in my mind, at this point, rely on the drug du jour to manage the constellation of symptoms that we were describing earlier. So again, this, in my mind, opens the door to thinking about some lifestyle factors. And this was a little bit of an older study from 2015 that I think at least opened this door in a systematic way, where at least in this study for about 130 breast cancer survivors, seemed to link this idea that obese individuals seem to have more problems with information processing, at least as an association. And again, it's hard to prove causation with these kind of studies. Those that were more active seemed to do better with executive functioning and attention. And those that had more sleep seemed to do better with performance and also with verbal functioning. So I'm going to follow up on this thread and think about this in a little bit more comprehensive way. These are some of the strategies that we really delve into in our cognitive rehab program, with the idea, again, that if we give our patients some insight and tools and strategies, then hopefully this will give them the motivation and the insight in managing these symptoms on their own. So thinking about exercise and thinking about whether this can be a treatment for cancer-related cognitive impairment. So I'll start this piece very briefly by highlighting this idea that we've known in the general population that those that have higher amounts of visceral fat, or so-called bad fat, right, the fat in around our abdomen, it seems to be pretty clearly linked with a number of issues like heart disease and diabetes and maybe even certain cancers, but it's also associated with cognitive impairment in the general adult population. And I mention this because we have to be, in my mind, and again, I may be a little biased in activity and how in this space, but we have to be thinking about how the body composition of our cancer patients may be changing with their treatment, especially when they're inactive. And this is not a study with cancer survivors, but I think it tells such a dramatic story. I just wanted to highlight it briefly. This was, I think 20 or 30 or so, small study of young, healthy college students, I think somewhere in Denmark or Scandinavia. And they basically wanted to very accurately measure their visceral fat, right? So this was a T2 weighted MRI. There's a cross section. And at baseline, for these otherwise young, healthy college students who were active, which means they were all walking 10,000 steps a day or more, you can see this is one individual's baseline measure, and of course this white here is the visceral fat. And then they had these otherwise young, healthy, active college students go 2 weeks, 14 days of being told to be a couch potato, which meant walking 1,500 steps a day or less. And then after the 2 weeks, they put them back in the MRI machine to measure their visceral fat. And you could see the dramatic difference, at least in this one individual. But on average, there was a 7% increase in visceral fat in just 2 weeks. 7% in just 2 weeks. And we have to imagine when we see this, what may be happening to our patients who go through, bone marrow transplant and they're in the hospital for a month, or a year-long period of treatment that involves surgery and then chemotherapy and radiation therapy and reconstructive surgery and all the rest, and they're in bed, let's say, the whole time because they're experiencing fatigue, which is real, but they're responding to that fatigue by just being a couch potato. We know that there are body composition changes occurring, and this is important because if we subscribe to that inflammatory hypothesis contributing to some of these cognitive symptoms, we know that this image is important because visceral fat, we know, is not just hanging out, taking up space, it's actually producing more of these inflammatory cytokines. And again, the reason exercise seems to be truly medicinal is there's been a whole body of research over the last decade that exercise truly can reduce inflammation. It can reduce these cytokines. And whereas we know that historically we always believed that muscle was important, so I can lift things and push things and be able to be involved in movement, which of course is true. We're also learning that when we do a squat or when we jump or run or do a pull-up, for example, and we're contracting our muscles are also producing something. And really, this wasn't recognized until over the last decade, where muscles produce something called myokines, which of course sound like cytokines, and I'm being far too simplistic about a complicated area of biology. But it appears that when these interleukins or myokines are produced system, where inflammation may go up when we have the flu, and as we feel better and we go back to our instinctive behaviors of hunting and gathering and we're contracting our muscles again, we had this natural process to bring down inflammation after it had naturally gone up to protect us from, for example, an infection. So myokines seem to reduce inflammatory pathways, and maybe that may be one of a number of reasons why exercise may be improving cognitive functioning. But there's a number, and I don't want to spend, we could spend hours talking about this. This was a really nice review that highlighted, different levels by which exercise may improve our cognitive performance in the general population, of course, but cellular levels, thinking about how it may modify the HPA axis and as I mentioned, reduce inflammation and be involved in neurogenesis, which has been pretty well evaluated. So there are these cellular and molecular changes that may play a role. There are these structural and functional changes where, in addition to improving perfusion, it may be contributing to neuroplasticity and connectivity in a number of ways, and that may be contributing to cognitive performance. And again, on just a behavioral socio-emotional level, we know that exercise helps people reduce stress, improve their sleep, improve their symptoms of depression or anxiety, and these factors may be playing a role in cognitive functioning as well. So there's a whole myriad of ways by which exercise may improve cognitive functioning. And I think finally, our goal is then, well, how do we compel and convince and motivate our patients to make the kind of behavior change that could probably make a big difference? So all of these studies up to this point were looking at really the general population. There have been at least 5 animal models that show that exercise can be helpful in structural alterations of the central nervous system and cognitive outcomes for those going through chemoradiation. There, up to recently, there were some human studies, but they were overall felt to be poor. And there were some insights that mind-body exercises such as Tai Chi or Qi Gong or yoga may be promising, partly maybe because it involves a gentle exercise, but also some of the stress management properties that it may encompass. But the reality is that there's been this feeling that we need larger and better structured randomized clinical trials using more robust kind of neuropsych assessments, longer interventions, and a better assessment of confounders to assess the impact of exercise on cancer-related cognitive issues. Now, as I said this, just over last couple of months, I believe there was a new study that looked at exercise patterns and cognitive function before, during, and after chemotherapy. This is a larger study of almost 600 individuals with breast cancer, and they looked at one of the prevailing subjective measures, which is known as the FACT-COG, and some objective measures of cognitive functioning before chemo, post-chemo, and then 6 months later. And again, as we expected, there was evidence that those who were maintaining the exercise levels before and during chemotherapy did better after chemotherapy ended in 6 months down the line. And again, I don't want to spend too much time on this, but just highlighting the importance again of how exercise we're now learning not only can it make a big difference in the general population in terms of their cognitive performance, but even for people who are being treated for chemotherapy, at least among breast cancer survivors. And the other opportunity is we know that physical exercise, as we talked about, seems to improve cognitive performance, and there's some evidence that perhaps cognitive rehab and cognitive exercises might improve neuroplasticity via other mechanisms. And whereas exercise, for example, may, through neurogenesis, create new neurons, for example, in the hippocampus, some of these neurons may die within a few weeks. But there's at least some animal model data that you can save some of these neurons and rescue them if you also integrate cognitive training. And I think one of the opportunities that exist is exploring the synergy between cognitive exercises and cognitive training and aerobic exercise, and how that may synergistically play a role in CRCI. So I think, to the best of my knowledge, that's still a big gap. So a little bit about thinking about nutrition and what we put in our mouths, and the kind of impact it may play in CRCI. And the honest truth is, I think we know very little specifically for our cancer survivors. I think there's some pretty good evidence, of course, that the Mediterranean diet and maybe having more omega processed foods seems to be associated with improvements in thinking and memory. And there was another study from last year that a fish-rich Mediterranean diet is associated with higher cognitive processes. I know this has been at least hypothesized in the cancer setting, where, and again, I think this is a much more complicated arena, and this is probably much more simplistic than what the reality may be. But there are some who would argue that omega-6, which may come, for example, in our processed seed oils, vegetable oils like corn oil, soybean oil, and whatnot, seems to have a downstream effects associated with an inflammatory pathway through arachidonic acid, and omega-3, for example, through fatty fish, for example, like salmon, sardines, etc., that may have a downstream effect that leads to reducing inflammation. And so there are some that have hypothesized that we need like a balance between how much omega-6 and how much omega-3 we need in our diets. Again, I think I personally don't think that it's totally well sorted out. But one of the ideas that the modern American diet seems to have a 15-to-1 ratio of omega-6 to omega-3, whereas, for example, the traditional Greek diet, Mediterranean diet, may be more on the lines of 2-to-1 or 4-to-1 or 1-to-1. And so that's an area that some have explored. Even though omega-3, EPA, DHA is hypothesized, I don't think it's well sorted out. Of course, people believe that DHA is involved in neurogenesis and learning and memory. And there are some studies that seem to suggest that supplementing with DHA may improve certain cognitive arenas, such as attention or processing speed. But the reality is, at least for using this as an intervention for our cancer patients and cancer survivors, I don't think we have much. So having studies of DHA as a neuroprotectant during chemo, to the best of my knowledge, has not been completed. And so it's really hard to make a recommendation on DHA and omega-3 supplementation. Now, I will mention, we presented this at MASC last year, where, again, we were just as a sub-study for another study we were doing, where we were collecting subjective cognitive symptoms among our breast cancer survivors who were enrolled in our cognitive rehab program. We just took a one-time snapshot of their omega-3 index scores, and we were actually surprised that there was a moderate correlation that between their subjective cognitive symptoms and their omega-3 index, which is a ratio of their omega-3 to omega-6 fatty acid levels. So I think obviously this needs to be replicated, and again, this still doesn't tell the story of whether intervening would make a meaningful difference. We hope to do this in a larger cohort later. Okay, sleep, again, this topic that we were discussing quite a bit during some of my really nice meetings yesterday. So just to kind of think about this in a global way. So for anybody that doubts whether lack of sleep can affect cognition, I would say either you haven't had little kids or you weren't primarily responsible for taking care of them. Because I could attest to this idea that we're not operating 100% if we're not sleeping well. And again, just anecdotally thinking about this, if you think about some of the greatest international disasters over the 20th century, and I just listed a few, Chernobyl, 3 Mile Island, Exxon Valdez, Space Shuttle Challenger, all of these events had somebody not getting enough sleep implicated in some way in these really huge international disasters. But to kind of break it down to the level of where we are in the cancer survivorship setting, I thought this study also painted a nice picture where you're looking at the prevalence of those who had either moderate or greater perceived cognitive impairment. Again, there's subjective cognitive experience, and comparing that to the degree of insomnia that they're experiencing. And you can see it's a pretty clear correlation where those that had the best sleep down here in blue had the fewest cognitive symptoms, and the more severe insomnia you had, you could see the worst cognitive symptomatology you had as well. And so then it really opens the door for thinking about, okay, well, what can we do to optimize sleep? And as a physician, I know our bias is often to reflexively think about a medication. But the challenge being, of course, as we're learning that, right, many of these drugs really are really just work because of a placebo effect, probably about 50%. And the other challenge is that many of these drugs probably alter our normal sleep architecture, right? So some of the, for example, the benzodiazepines, right, Valium, Ativan, Klonopin, etc., they reduce the amount of time that we may be spending in REM sleep. And we know, for example, REM is critical for the memory pathway. So, you know, we were having some nice discussions with Dr. Schatz and her team yesterday about this idea of the glymphatic system and how some of the neurotoxins that are generated in the brain during our normal daily processing is actually cleared out through this system more optimally when we're sleeping, probably. And there's no evidence that a drug allows for that glymphatic system to work as well as so-called natural sleep. So then when we think about non-medication options, of course, CBTI, cognitive behavioral therapy for insomnia, seems to be the gold standard. Again, there's some evidence that exercise may be helpful, and I'll come back and talk about bright light therapy, which is this idea that some patients may get 30 minutes or so of these light boxes, 10,000 lux, for example, per day to kind of help with their circadian rhythm, and we'll talk about what role that might play. So thinking about cognitive behavioral therapy and insomnia, it's been, again, unequivocally effective for the general population. And more recently, it's been looked at for not just improving sleep, but thinking about what role it may play for some of the cognitive symptoms that our cancer patients may be experiencing. So there have been at least 16 studies that evaluate the effects of CBTI in our breast cancer survivors. And again, it seems to be associated with improving sleep and mood and a number of cognitive, general quality of life dimensions. But no one's really looked at, to the best of my knowledge, of intervening with CBTI specifically for primary outcomes looking at cognitive functioning. So I think there's still an opportunity to look at this in a more systematic and cohesive way. I just alluded to the idea of possibly thinking about the role of light therapy for cognitive symptoms. Again, in the general population, there's some evidence that light therapy can modulate brain functioning, especially with sustained attention. There's a study in Iceland underway right now looking at bright light therapy for patients undergoing chemotherapy, and they're looking at specifically at cognitive functioning. So at least I'm interested in seeing what that's going to show. And there's also a study at Mount Sinai to look at the feasibility and acceptability of bright white light therapy as an intervention for cancer-related cognitive symptoms for long-term survivors of stem cell transplantation. So some work being done, and again, it may just be another possible intervention that could be considered. And finally, on the lifestyle realm, we do integrate a section on mindfulness and mindfulness meditation, as this might be a helpful intervention for some. And again, in the general population, we've known for some time that it may help with a number of cognitive domains, such as working memory and attention. There's some evidence that long-term meditators, right, people have been doing this for 10, 20,000 hours, or have epigenetic changes that may be protective in cognitive functioning. And there was a more recent study looking at breast and colon cancer survivors where they were randomized to mindfulness-based stress reduction versus a kind of active control of fatigue education in a support group. And again, there was evidence that the mindfulness group did better at attention scores at T2 and T3 and some of the neuropsych testing. So again, in these small studies, there's at least some insights that this could be of significant value. But again, I think similar to the other arenas we've been discussing, there's an argument that larger randomized clinical trials with more comprehensive cognitive measures are probably needed to assess the efficacy of mindfulness-based stress reduction on cognitive symptoms in the cancer setting. And social connectivity is another idea that we talk about in the program. And again, we've known for some time that chronic loneliness has a number of health implications in the general population, in how it can change virtually every important system, our cardiovascular, immune, nervous system. In the general population, we know that it's associated with higher mortality rates, and that it's associated with a higher likelihood of experiencing pain or depression or fatigue. And again, all of these symptoms are associated with cognitive decline. And there's also some evidence, as you may be aware, that chronic loneliness is associated with a higher mortality for certain cancer types. This has been looked at breast and ovarian for the most part, to the best of my knowledge. And you couple that with this idea that, again, in the general population, loneliness is a risk factor for poor overall cognitive performance, faster cognitive decline, and it's been linked as a risk factor for cognitive complaints among our breast cancer survivors. Now, one of the things we did in one of our studies, that this is actually submitted for publication, we're waiting to hear back, and we were surprised when we saw this. So we were looking at these different cognitive domains, these PROs, subjective assessments for cognitive functioning. So these include the FACT-COG that you see and the PROMIS measures, looking at different cognitive questionnaires. And we were really surprised that when we correlated this to the to loneliness scales, using the UCLA loneliness scales, across the board, there were really dramatic correlations with the symptoms of loneliness and the symptoms of subjective cognitive impairment. And what was interesting, and I don't have the slide for this here, is when they went through our cognitive rehab program, which is done in a group setting. So, so they're validating their experience by, sitting with others who went through the program. The people that had an improvement in their cognitive symptoms after the intervention ended also had a decrease in a way that correlated tightly with their loneliness symptoms. So it really opened the door to thinking about how possibly some of these symptoms really may go hand in hand. Again, much more work needs to be done. So if we take a step back now and look at some of the guidelines for managing cognitive symptoms from NCCN, for example, this is from this year, right? It's intentionally, I leave it as a busy list because I could imagine, right, if anybody is trying to manage these symptoms and they just see this like laundry list of things that you should be doing, and I'll just kind of, since I know this, they talk about using organizational strategies or managing depression, managing sleep, managing fatigue, teach relaxation strategies, right? I could tell you, at least from my perspective as a clinician, there's no way I can do all of these things in one or more clinic visits, right? It's basically impossible. And so it's these ideas that really catalyzed us to work on developing our cognitive program that we call Emerging from the Haze. It was originally 6 weeks because we had people coming in person. We've now pivoted in the virtual format to kind of spread this out over 10 sessions, since we don't have to have everyone fight the traffic to come to our center at Cedars. But this was a basic overview of the program. That, again, that the content has stayed essentially the same, but it's just been diffused over a larger period of time to make it more palatable when it's being delivered through Zoom. And so again, part of it is really teaching and allowing our patients to master some of these ideas of how optimizing lifestyle factors may contribute. And again, our neuropsychology colleagues have been really taking the lead on working on the cognitive rehab strategies, the stress management strategies, thinking about attention, executive functioning, and et cetera. And so we started this because we didn't have any programs at our institution, and there really wasn't much to take from it. So we just wanted to help our own patients. And so this wasn't part of a study. We were kind of retrospectively looking back at our own data, and this was looking at the FACT-COG. These are the 3 different domains. And with the FACT-COG, the higher the score, the higher quality of life. And what we basically found, and again, there was no control group with this, is at baseline, you can see, hopefully you can see my arrow moving, they had the highest cognitive symptoms, for example. And then the second time point here is right after the program ended. And then we saw that there was, maintenance and improvement in the months after. And we saw that same pattern play out with quality of life and perceived cognitive ability. And so this really got us thinking that maybe, we should be a little bit more systematic at looking at this. So I had the wonderful opportunity to partner with one of my colleagues, Dr. Jamie Myers at the University of Kansas. And we virtually delivered, this is before the pandemic, our program. So it was delivered live to our group at Cedars and also broadcast live to groups at the University of Kansas. And we did this over the period of a year. And we were primarily interested in looking at, in this prospective fashion, how the Haze program can impact subjective, right, self-report cognitive changes based on promise measures in the FACT-COG. And we compared that to a waitlist control group. And this study was limited to breast cancer survivors who had finished treatment but were within 5 years of receiving chemo and or radiation therapy. And again, we published our study last year, and we basically found, right, that compared to, so the blue is the intervention group, the red was the control, that subjective cognitive symptoms improved in the intervention group, and there were statistically significant differences compared to the control group over time. And then the pandemic hit, right? And then so we pivoted with our program, and we did everything virtually at Cedars-Sinai and at Kansas, primarily to see if we did it all on Zoom, if it was feasible and acceptable to our patients. And and so we just presented this at ASCO Quality Care Symposium. And I just want to be brief with this to save a few minutes for questions. We found that the virtual delivery of the program was feasible and it was acceptable. And again, we still looked at loneliness based on the UCLA loneliness scale. And again, I just want to highlight that even in the virtual format, it seemed to be an important predictor of both cognitive functioning and one's desire to change their behavior when we look at that intention to change behavior. So I personally think that's an important area to keep looking at. So then we had this question where we have this program, right, and we would run it with groups of 10, 15, maybe up to 20 people at a time. But how do we get this out there? And because we can't live Zoom these groups broadly, because there still is a group dynamic that occurs. And so, yeah, we could think about the trainer model. But the challenge with that is we've realized that many smaller institutions don't have the facilitators that are able to commit the time and develop some of the expertise to actually deliver the content. Of course, as I learned yesterday, your team clearly does, and so we're really excited to partner with that model, but many institutions do not. And so what we've been working on now is, and this was something I never thought I'd get into, but this is actually myself and my colleague, Dr. Jeffrey Wertheimer, neuropsychology colleague. So we actually are going through this whole video production process where we're recording this content with the whole team to try to make a standardized delivery of the production that can be shared with other institutions, and then can be, somebody locally can just facilitate the group dynamics. And so this is the study that's starting in January. We're slated to start January 12th, where we're enrolling patients. And again, anybody on this talk is welcome to refer patients, because everything's done virtually. We're enrolling 90 patients with different cancer types. So we're really trying to broaden the inclusion criteria. Received chemotherapy at least 6 months ago, but within 5 years. And they're going to be randomized to either my colleague and I delivering the intervention live, but in a virtual format, versus being run in a group where they're getting the content in that pre-recorded video production that I just alluded to, versus a waitlist control. And Jamie Myers had this award funded for this study, and she also is going to be including a sub-study to look at what we call the MindCap sub-study, which is basically looking at the feasibility of a mobile application to assess for cognitive functioning. So I know I kind of went through a lot of information. I really want to again, thank you all for the invitation. I really want to commend, because when I had a chance to talk to Dr. Schatz and Michelle from your team, and thinking about the really rich and sophisticated assessment programs that you have at your own institution for managing these cognitive symptoms, it really is something that I hope we can learn from and collaborate with in the future in whatever way makes sense. So I hope you are incredibly proud of the services that are available to you in your own institution. Again, I had a really lovely virtual visit yesterday, and I thank you for the invitation. And if there are any questions, comments, feedback, I'd love to take them at this time. Thank you all so much.
Thank you, Dr. Asher. That was amazing. And I appreciate your candor about, we all know a lot of these things are so pivotal to helping cancer-related cognitive impairments. But you're right, it's hard to find the time to do that. And I want to let everybody here know kind of a plug for our own clinic. As he alluded to, Dr. Rana Schatz with neurology and Michelle Kirshner have established a cognitive clinic where they are doing the neuropsychological testing, and then partnering with one of our speech and language pathologists to do some cognitive focused rehab. But we're going to be piloting, partnering with Dr. Asher to kind of bring this emerging from the Haze program here to our institution so that we can really do a deeper dive into helping our patients with cognitive impairments. So please feel free to make referrals to our cognitive clinic. It's done by placing referral to neurology, to Dr. Rana Schatz, and just specifying in the comments. And then a second plug is for our exercise program, right? We have, we see patients before, during, and after exercise. We're currently piloting doing it in the infusion suite that we're doing at the Barrett, and probably next year going to be taking that up to Westchester. So just to apprise everybody of, we've got some resources to help you with your patients. And if anybody has any questions, feel free, don't be shy, and speak up.
Hello, this is Sinan. Thank you for the nice talk. I'm one of the Hem-Onc fellows. I have a question about the cancer survivors with cognitive impairment. Do you see the same radiologic and histologic changes you see in other cognitive impairments? Do you see the changes, at least, for example, like the tau things and the amyloid deposits? Is there any data on that?
This is actually interesting. We were talking about this. This is an area of interest and expertise for Dr. Schatz, who I know is looking at some of these CNS changes. I don't know if is she on? She's not on right now. So to the best of my knowledge, I'm not aware of any. I know she's investigating and exploring this arena. I think when I was talking to her, she was talking about how there are some of these changes, but the concern was that they may not necessarily, they may have been pre-existing, and so there may be some catalyzing some of the development of the neurodegeneration from treatment, but that, to the best of my knowledge, the main hypothesis for cancer-related cognitive issues, when it's not confounded by other factors, is the inflammatory pathway and mitochondrial dysfunction. But I think something that certainly needs to be better looked at. I think it's a great point.
Thank you.
And if nothing else, I mean, just since you have this amazing program locally, I hope I just conveyed this idea that the symptoms, whatever is causing it, is incredibly common, and many of our patients want some kind of support in improving their quality of life and learning how to navigate through that. So I hope at least that much got conveyed.
Melissa, I have a question.
I just wanted to thank, I just wanted to thank Dr. Erickson's groups and Dr. Asher for talking about this very pertinent topic. I'm one of the swallowing therapists with the cancer team, and as a rehab person, we encounter this all the time because we spend an hour or so with these patients, giving them exercises and counseling, and the cognitive impairments in these patients have been so drastic and so impairing to our outcomes that I feel like this topic is extremely timely and very important to our cancer rehab program. So thank you so much.
Thank you very much.
Dr. Asher, thank you for a very lovely talk. I'm one of the GI surgeons at our cancer center and one of the co-directors of the cancer center. And one of the things that we often see after complex surgery, especially for patients who've gone through chemotherapy and then surgery, is a short and long-term cognitive decline. And Melissa and Michelle Kirshner have started a rehabilitation clinic for these patients. So the question I have for you is, what should the rehabilitation clinics incorporate to try to alleviate some of these some of the cognitive decline that we see in these patients that can sometimes be very troubling and prevent recovery from the interventions that we perform on the patients?
That's a great question, because I know prehab is obviously a hot topic in the area of oncology rehab, and I would argue most of it is focused on the physical domain. So how do you buffer someone in terms of their physical conditioning before they have a major GI surgery, for example. But if my best hunch is that, and let me give an example. So if you think about post-mastectomy pain, which is a little bit different population than what you're dealing with, if you look at one of the major risk factors for post-mastectomy pain syndrome, these are symptoms of significant anxiety, distress, catastrophizing at the prior to the surgery, coming into that period, leading to persistent, or at least maybe with the wind-up hypothesis contributing to some of the central sensitization pathways that may be occurring. And if we believe this idea that these mood symptoms often are correlated or contribute or catalyze some of the cognitive symptoms, I would have to imagine that teaching some kind of relaxation or biofeedback or mindfulness program, I imagine could be again, needs to be assessed, but should be an important part of a cognitive preventative approach.
Dr. Asher, I wanted to mention as part of that prehab program, Dr. Barbara Walker actually has created some supportive videos, which we are providing. So we really are trying to be mindful of that particular element. But I think actually I'm really intrigued, because I really think this other component of sleep, which we kind of really we see as foundational in our clinic, that maybe that conversation and evaluation should start with these patients, surgical patients, at time of diagnosis. I'm very intrigued about that idea, and I think it's very doable to do that. So just kind of a thought.
I appreciate you bringing that up, and I just want to emphasize, and I think we talked about this yesterday, where we published a paper with Patty Gans and her team at UCLA looking at risk factors for persistent fatigue, 18 months after the treatment has ended. And there were two factors that really seemed to predict, and it wasn't the chemotherapy or the type of surgery or the type of anesthesia or whatnot. It was sleep disturbances at the, that pre-existed the diagnosis, and some kind of pre-existing depression, anxiety, mood disorder. So those two factors really seem to predict persistent fatigue. And again, from my perspective, cancer-related fatigue and cancer-related cognitive impairment are, in a sense, different sides of the same coin. I know they're not exactly the same. So I have to imagine that optimizing their emotional state, and as Michelle just alluded to, which and that may relate to sleep disturbances too, but optimizing sleep should be two important places to start also.
All right. Well, thank you so much, Dr. Asher. It has been a total pleasure having you visit with us yesterday and today. You've been a wealth of knowledge, and we look forward to continuing to partner with you to provide improved care for our survivors.
Thank you all so much. I really appreciate the opportunity. Thank you.